of the Brazilian Hernia Society and aims to bring more Brazilian and Latin America to be AGA's Congress. Natalia?
Anna. Anna, it's another colleague. She is just finished her medical school. Anna, just please introduce yourself.
Yeah, thank you. Hi, everyone. I'm very happy and honored to be here. My name is Anna. As Natalia said, I recently graduated from medical school here in Brazil, and I will apply for general surgery residency soon, hopefully, in the US, and very interested in surgery, especially in the hernia field, and I'm very happy and honored to be here.
She received awards in the last meeting.
Yeah, you're going to talk about that because she's brilliant, and you're going to know Anna. You're going to hear about Anna a lot. So I'm Natália Pascotini. I'm a general surgeon from São Paulo. I'm a member of the Brazilian Hernia Society and a member of the AHS Diversity Committee. And we are very proud and honored to have these we are going to be 5 brilliant and skilled surgeons here. So Dr. Archana Ramaswamy, it's the current president of the American Hernia Society. The American Hernia Society is one of the biggest and most important hernia societies in the world. Dr. Vedra Augenstein, she is the future president of the AHS, and here we see how interesting this society is, because there is a rise of women in a natural way. And when I say this, I have a phrase in my mind that natural is not because it's natural, it's hard work pays off, and that's about natural that I'm talking about. Dr. Andrea Pakula, it's a reference in ACS and robotic surgery. She is a member. The first when I remember her, that when I first read about something about the Da Vinci 5, I saw a familiar name, and she was there. Like, she was one of the first surgeons of performing a robotic surgery in the new Da Vinci platform. Dr. Sabrina Drexel, that is coming in the event just in a few minutes. She is also a reference in robotics. She performs super complex cases in abdominal wall surgeries, and that we are going to talk about some complex cases that she performed. She is super polite and willing to teach other surgeons. I was able to see that in the last year cadaver lab of the AHS. And last but definitely not least, Dr. Caitlin Houghton, that she is late, but she is going to be with us. She is a reference in upper GI and hiatal hernias. She performed a huge surgeries on that, and she is also a hernia friend. So thank you again for joining us today. And speaking up about the AHS meeting, I first need to ask you, Dr. Archana, what is to be like on this leadership position, and what was the challenges that you have leading this institution as important as the AHS?
Well, thank you, Natalia, and thank you for inviting me and inviting this great panel and letting us kind of continue our partnership. I think that, as you probably know, we've always had a partnership with all of the Americas. And there was a time period, right, where American Hernia Society was actually called America's Hernia Society. But then clearly, like all of the other societies grew to such strength, including the Brazilian Hernia Society, that we were like, well, we can't speak for everybody. You all stand on your own. And we changed our name back. That doesn't in any way decrease our strong relationship, I think, with the other hernia societies within the Americas. And we very much appreciate that. I think that this is a great society of, as David Chen always puts it, it's all a bunch of friends where we like to work on probably what is not the sexiest operation, if you want. And it's obviously not just one operation. We do so many operations, but in the mind of many people, it is just one operation that we do. And so we're very like-minded in terms of being able to advance the field of hernia, ab wall, core health, and just kind of identify where we can continue to push the envelope and keep improving in terms of our outcomes. I think probably one of the things that you mentioned, which was in terms of the women on the board as well as on the exec and how it felt that it was natural. I think it becomes natural. I don't think any of this starts out natural by any means, and it has to do with the fact that representation matters, and it has to do with the fact that you make diversity one of the important factors that is always considered. And then eventually, I agree, we all hope and expect that this is something that will become natural and that it doesn't have to be that we think about it. And of course, female gender is only one of the things, right, that's encompassed within diversity, as you obviously know, with all of your great work with the DEI committee. But it is, I guess, one of the more visible ones. But at the same time, I think that we and other societies recognize that different viewpoints just make us all stronger.
For me, it's interesting this idea because SBA is young than AHS, but this time is the first time the woman come to the boarding. It's very changed the society. Many humans coming to society, probably because the AHS. For example, in the past the visit Natalia visit Vedra changed the mind, and the Natalia come to the boarding for the SBA. It's interesting the difference.
Yeah, it's Anna can talk about the award that she gained about female factors that is different of what AHS is doing. So yeah, AHS have several actions that support and encourage surgeons and development of their careers. And thanks to the Observer Grant Award, I had the opportunity to go to the Atrial Health and follow and learn from Vedra, Dr. Vedra Augenstein. And this has changed my life. This improved my career. This improved my practice, elevate my career. And I cannot put on words what this made to my routine, to my patients here. So AHS, it's, what AHS do for the surgeons that are in, trying to develop their career, it's different. It's awesome. This is a great work. So this is, thank you. Thank you so much.
For me, I'm afraid I won't have enough clinical experience as a surgeon because I'm a student, but from the perspective of a student, it's really amazing the opportunity we had in the AHS to present our work in the meetings. And as I said, despite not having clinical experience to share, I have always felt really comfortable during the meetings. And it was always an open space to share the research and to discuss mistakes and also grow from it. And it's very inspiring for me also to see female leaders in these positions.
Yeah. So Vedra, the meeting this year is on September 12th through 14 in Chicago. So can you tell us about cool stuff we are going to see on the program this year?
Yeah, so I mean, I think you're gonna. I mean, I love the conversations. By the way, thank you so much for inviting us. This is just great to be able to meet. You know, it seems like we're in person, but we're gonna be in person soon. I loved having you in Charlotte. I think it is a great thing that AHS does, and I think you're a great spokesperson for these programs to continue because we have the funding, and if we can impact more people like yourself. I think that would be amazing, and I think very soon people are going to be coming to see you as well, and you'll be doing the same. So kind of that, I think that's kind of the trademark, I feel like, of our organization. And I think it's because of the leadership, honestly, because I'm part of a lot of other organizations, but I've never seen this kind of inclusiveness in everything and people just wanting to kind of help each other. And I think we have some really great leaders, Archana, we have David Chen, we have Conrad, we have a lot of people that are very welcoming to everybody and really want to share and be helpful, people that are not just trying to promote themselves, but people who are really kind of trying to pull everybody up. And I think you really see that. So anybody who comes to the meeting, it doesn't matter if you're a student, it doesn't matter, if you're like an attorney or somebody, you feel very included in all the hernia activities. Hernia family is a great family, and I think we all kind of enjoy ourselves. So I think you're going to see a lot of that. I think the program is going to be exciting. We're going to see a lot of young people presenting, part of the main sessions. We're going to actually have live cadaver dissections as well. So that'll be a little bit different. So lots of great abstract presentations. I think it's going to be a fun-filled program. And of course, there's going to be a lab at the end of it. So if anybody is interested in doing some kind of hands-on stuff, these mentorship programs are phenomenal because you get to work with a lot of, phenomenal surgeons in certain procedures that, maybe you've done them before and you want to brush up on it, or you want to expand and do a procedure that you've never done before. So that's a lab that takes place the day after the hernia meeting. So so lots of great stuff. The program's online, and I encourage everybody to check it out and join us.
Nice. Thank you, Vedra. So Gustavo, I think Gustavo can talk a little bit about we are going to have a meeting before the AHS Congress. That is why we are here talking to you. We are going to, the aim is to bring together Latin Americans and Brazilians to the AHS Congress. So Gustavo, can you please tell us a little bit more about the Hernia Week?
Yes, of course. I'm so glad to see this picture from my screen. A picture with so famous names of surgeons in the hernia world, like Vedra, Archana, Sabrina, Andrea, and younger female surgeons like Natalia and Carolina, Jacqueline. I'm so glad. Thank you for coming, for joining us. And I am Gustavo Soares, current president of Brazilian Hernia Society. And we started a few months ago a project to take the majority, not majority, but a great number of the surgeons from Latin America to share experience with the US, with Europe, and the first time that this kind of event will occur, probably not. Well, of course, will occur in September. Our idea is to promote a meeting before the AHS Congress called Hernia Week, and every event will call the name of the Congress that we're trying to visit. And in this time, Hernia Week Latam in AHS 2024, and our program is start with a cadaver lab in Miami for 3 days, and other 3 or 4 days in Chicago with this great event that is AHS Congress. So please share this idea with your colleagues, and I'm sure I'm certain that will be a great event for every surgeon from Latin America. We have the surgeons in the US with a model, because it's interesting for us to see how you work, how you do the things, and for us is a dream. Make this possible for great numbers, several surgeons in Latin America. So it's a few words for you. Thank you, Natalia. Thank you, everyone, for your time, and I hope you see in person in Chicago. And thank you so much for your time.
Thank you, Dr. Gustavo. It's going to be great, I'm sure. So talking about the Congress and the upcoming event of the Hernia Week, Dr. Andrea, I want to ask you about, I know that this is really cool that you have a cadaver lab. So can you talk a little bit about the cadaver lab to us?
Yeah, absolutely. And obviously I echo everyone else, and thank you for the invitation. This is really great, just to see and be a part of. So with respect to the cadaver lab that Vedra was alluding to, what AHS has put on over the last several years is what is referred to as a mentee to mentor, mentor to mentee program. And so we have 20 participants that are going to be partnered with faculty from all over the world, specializing in a variety of different hernia techniques, whether it be open, laparoscopic, inguinal, robotic, what have you. And so each faculty is paired with 2 mentees or 2 surgeons that are wanting and interested in expanding their hernia, skill set. And so it's really a great program, because basically I was a mentee at one time, and I had the opportunity to experience it on both sides now. And you really develop relationships with these surgeons and with the other surgeons within it. Like Dr. Augenstein said, it really is truly a hernia family. And these are people that you can go to and learn from and get advice from. And even teach others, as it goes through. So the lab is held after the meeting. We filled it very quickly this year, and I think it's been that way for the last several years, in getting people that are very interested in taking this cadaver lab. So I encourage anyone that is interested definitely to do these labs as they come up with the various meetings.
Yeah, this is really cool. I think this is a great opportunity, and every surgeon, even in the younger age, or if you are going to try to do more complex surgeon, it's great to learn from the best. And the cadaver lab, it's that. This is great. Sabrina, hi. I know that you are here. Hi. Talking about teaching people. I know I saw you teaching in the cadaver lab last year. It was great TAR procedures and complex procedures. But I'm going to ask you something about, not only about the Congress, but I know that you have an observer site of robotic surgery on your hospital. And I have to, I really want to ask you that it's just for American surgeons, or surgeons from abroad can go and see you operate?
That's a great question, and I'm not sure I know the answer to it. But yeah, first off, I can talk about teaching at the cadaver lab. I've gotten to teach robotic TAR the last 2 years, and I've taught at other societies, and by far and away the American Hernia Society, the way they put it on is that you know who exactly you're teaching before you walk in the door. You've had conversations with them, you've talked about their goals, you've talked about their practice and what they're hoping to grow. And so that's been just phenomenal that you already have a relationship before you even meet these people in person. And even my mentees I taught 2 years ago are still sending me texts of, hey, what do you think about this CT? And, you know, how would you approach this case? And that's really the beautiful part. It's not just one day. It's like you now have this relationship with someone and I want to see their practice succeed. That's why I love teaching. And so it's really been an ongoing, you know, long-term relationship. And I feel like that's what these congresses and specifically AHS gives us. Is I'm still a young surgeon. I'm only 4 years in training. There's people on the screen I reach out to help and ask questions for cases that are challenging. And it's always felt like a very welcoming environment with very little judgment. And so I'm always excited to give that to other people too, of what advice I can. And so, yeah, I do have a hernia observation site through Intuitive that's hernia specific. And I should ask them. I'm sure I do have hubs so people can come remotely to my OR, which is very fun. And I know Andrea has that as well. And I'm sure people can come internationally and watch cases, which is great for learning cases and techniques.
Yeah, they can. I'll chime in for you there, Sabrina, because I actually have a surgeon from Denmark that's coming in October, and they reached out through Intuitive. So yeah, they for anybody, Natalia, if that's interested in any of these sites, going through Intuitive can get the international surgeons there as well.
Oh, I think you're muted.
Yeah, I think you're muted.
Oh, I'm so sorry. I'm so sorry. I just muted because we have kids here.
It's good. I'm in the same room.
Yeah,
and to talk, and your microphone is off.
So yeah, I'm hearing Paulo talk here and here. So I'm so sorry. I think Caitlin is not with us, or she is with us right now. No, she is not. Okay. So I want to ask all of you about something about robotics, because it's different from United States and Brazil. You know, like Brazil, we have a little bit more than 100 robotic platforms. And in my idea, what I saw when I went to United States, that you perform all the surgeries robotically. This is true, or some surgeries you think that I prefer to use laparoscopic surgery, or that it's not real. You use only robotics. You can just feel free to answer that, because it's a question that I'm with myself.
So I think everybody's a little different, and I'll give you my viewpoint. I see the robot as a tool, and I use it if I think that there's benefit for the patient or for me. So in my mind, I have a little bit of kind of a criteria of the patients that I want to use the robotic tool, as opposed to those that I think it's going to be fine if I do it laparoscopically. And I just go forward with that. And I think that it's going to be also very different based on some very local issues, such as access to the robot, as well as if your turnover times are any different between laparoscopic cases and robotic cases.
Yeah, I would echo that.
Sorry?
Go ahead.
Go ahead. No, the difference for Brazil and US, the US, there are 5,000 platforms in this time.
Even
in
more.
Brazil, there are 100 platforms. In the big hospital in Brazil, no more 2 platforms in one big hospital. For example, the Einstein Hospital. It's a very different.
And do you think residents should learn open surgery before robotics?
So I don't know. I'm sure people have thoughts on that, but this was the conversation that happened when I was a resident in the last century, if you will, that we used to say, oh, everybody's doing laparoscopic cholecystectomies now. What's going to happen? How's anybody ever going to be able to do an open cholecystectomy? Should we teach that first, right, before we do laparoscopy. We never did. And then we found that, you know, the conversion rate was very low. But regardless of that, I think that we never went to that point where we felt that we needed to do that. And that's a little bit of the same thing now, where we talk about if our residents only do robotic cases, is that going to be an issue? Are they ever going to know how to do a laparoscopic case? We never had this conversation when we started using something like, you know, an ultrasonic dissector, right? Or one of the vessel sealing devices. We didn't say, oh my God, what are we going to do? How are people going to know how to use clips if everybody starts using these as we move on? I think that technology is advancing and we figure out how to use it without and set ourselves up, right, for success in terms of making sure that the rest of the curriculum does cover the appropriate anatomy and the knowledge on how to proceed with conversions as necessary.
Yeah, I agree with Archana 100%. You know, I think there's room for everything. And I think our residents, we need to try to train them in everything. You know, you can't do, I mean, I think robotic, it's, you know, it's an extension of laparoscopy. We need to have a camera, and I don't know if we're going to be hooking it up to a robot or if we're going to be clearing some adhesions with scissors before we can hook it up to a robot. But, you know, you have to have certain skills to do some kind of adhesiolysis laparoscopically. As we advance, we get more platforms. I think we're going to be doing more robotic surgery if we have a robot in every room, because even some cases where we think, I'm just going to take a look, there's no way I can do this robotically, a lot of times we're succeeding. So I think when you came and visited me, we were doing a lot of robotic procedures, but I do a lot of paniculectomies and big open ventral hernias as well. You know, so there, I think there's room for all of those. And I think definitely we should keep training our residents to do those.
Nice. And you, Sabrina, in your experience, what do you think?
Yeah, it's funny because I'm on that. I didn't do more than 2 open choles in training. So when people say like possible open, I'm like, I'm never going to do possible open, but my threshold is different because I feel more comfortable being laparoscopic or robotic than open than a surgeon that maybe trained 15 years before me, and that's okay. You know, it's all about being comfortable with your skill set. I definitely do lap and robotic in my practice. I believe in robotics. But there's a time and a place for laparoscopy, and certainly knowing that skill set is important. You know, we'll see how things evolve. We are very fortunate in the United States to have access to robotics, but even at my hospital, I still have access issues, and there's a time that I don't have access to a robot and do things laparoscopically. But I think it's very individualized.
Yeah, Dr. Andrea, what do you think about you? That I know that you are an advocate, like, for robotics. What do you think about that?
Yeah, I mean, I agree with respect to the training aspect and residents. I think kind of like what Sabrina said, there are some cases that it's standard, right, to do these cases in a minimally invasive way like a gallbladder. So necessarily training, or is it necessary to train open? I don't think we're going to do that. We train people to be able to do this laparoscopic or robotic. There are some procedures, though, like the big complex abdominal hernias, that we have to potentially do open. My approach is a little different. Obviously, my hospital, I have full access to the robot for everything, both electively and emergently, and I approach everything robotically. However, there are cases like complex hernias, or maybe they have a fistula or something that I don't necessarily think the robot is going to benefit much, or I'm going to have to do a portion open. So I probably will just do that open unless it's like an extensive adhesiolysis. So access is a problem. I am fortunate where I am to not really have much access issues, but you can't do, like Vedra said, robotics is just the evolution of laparoscopic surgery. Every robotic procedure starts out laparoscopically, whether it's just entry or doing adhesiolysis or what have you, and even identifying where the problem is if you're not sure, you know, if it's a not a planned case. So we all will gain the skill sets, I think, that we need to do the procedures, but that's the beauty of surgery. As it evolves, we evolve with it. And I think that's nice about hernia. I mean, look at the hernia techniques that robotics has allowed us to now do that we weren't doing, you know, however, 5-10 years ago. So
I think for surgeons who don't have robots, like any, I mean, I think most of the world is struggling. And I'll be honest with you, you know, Paula, we have 4 robots in my hospital, and we fight over robot time. Like everybody wants to do everything with the robot. And when we say we want to do a hernia, they look at us like we're crazy. And they're like, but I'm taking care of cancer patients. Like, why can't you just fix a hernia out in the hallway somewhere? So we struggle even in the United States with that. But I do think, you know, laparoscopy is an important skill to teach the whole world. Because then the conversion to the robot is going to be much easier. You know, I think that learning curve is going to be much quicker, especially as the platforms and the training protocols and mentorship and videos, you know, it's not like 10 years ago, it's getting way better. So I think that's one thing we need to, you know, teach the whole world is just laparoscopic stuff initially.
And I think as all of the new platforms come in, that focus of different companies is going to be, right, to be able to market to the world. And they're not focused on the US anymore, honestly, right? They're looking at Asia, they're looking at South America, they're looking at, I mean, Europe, I'd say, already kind of gotten in there quite a bit, but there's still other platforms coming out, and competition is good.
Yeah, I think in Brazil it's like that because we have a little bit more than 100 Da Vinci platforms, and now the market is open to other companies, and I think maybe this could help us because, you know, now the patient has to pay for use the robotic platform, and it's expensive. So this is like a barrier to to use the robotic platform. I am just in my training to use the robotic platform because I don't have patients to operate in. I don't have a robotic platform available for me. So when I went to United States, I was just like a kid in a candy store, you know. Oh my God, this is a robotic. You have all the materials, you have all the great stuff. I want to move to United States to operate, but it's a different reality. And yeah, we have to. I think we have to work on what we have now, and yeah, it's different. The when you're going to think about the residents in United States, they are choosing the hospitals. I think, let me be honest here, please. But they are choosing, okay, I'm going to do my residency here because you have a robot, but you have 2 consoles, so I can operate and learn from. In Brazil, we are not at this point yet. We are just, okay, they have laparoscopic. This is really, really cool, you know, because in hospitals here that are public, the like public health system, we have just open surgeries in some of them.
I think about. Continue, please, Archana.
Sorry, I was just going to say one interesting thing that I've seen here is that I've changed institutions over the last year and a half, and the one that I joined is very robot heavy, which is very dissimilar to where I came from. And I still do most of my gallbladders laparoscopically, and the residents will run over to do the gallbladders with me out of excitement because they do mostly robotic gallbladders with their other attendings, and they're like, I need to make sure that I learn this. So I think our concerns about trainees only knowing how to do one thing may not be as valid as we think it is, because there are a lot of skills that are transferable in terms of these procedures. It's just a tool again.
Yes. I think it's the same for Archana. The competition for South America solved this problem, probably. In this time, I use the SI robot. I don't have X in my institution. But the competition, the Hugo versus and other platforms help the South American. But I think the US in 5 and 10 years and change the laparoscopic is over, and the robot is the first way. But the open is continue. I have the same thing. The Vedra talk. The paniculectomy is not necessary to use the robot. It's just the open procedure and remove the skin. Anna, do you?
Yeah, it's not just it's a big complex surgery that you remove
Yes.
skin. Yeah, I saw Vedra, and I talk about it to Paulo, that you perform a lot of open surgeries too, that it's very complex. And I don't know, like 7 the patient have 7 surgeries, and then they got into your service. This is very complex. Maybe robot, it's not the option. That's okay. But I forgot
I have one
about.
question. Anna, how many robot surgeries did you know in your medical school?
I haven't seen surgeries with robots during my medical school. The only experience I had was during the clerkship. I went in Miami, so I saw it there, but in Brazil, I have no experience with this.
So we are in a hernia meeting, and I want to ask you, girls, what make you like choose to do a fellowship in abdominal wall surgery? I think you can start with that, Dr. Augenstein.
Okay, so I wanted to do a minimally invasive fellowship. My residency was mostly open, and I feel like it was very vascular, surgical oncology, and trauma heavy. So I felt like, as a general surgeon at my age then, this was 14 years ago, I still felt that I needed to know how to do a laparoscopic colon procedure and a laparoscopic inguinal hernia. And that was the only reason I wanted to do a fellowship. And then I ended up in Charlotte, which I had no idea was a hernia. I did no research, and then ended up doing a lot of hernias. But, I think still a lot of those procedures, I think it's just more laparoscopy. I think we're constantly making our residents learn more and more and more, and there are all these new tools coming out and things like that. But like Archana said, a lot of these skills are transferable. So that's the main reason. That's my story.
Yeah, for me, I thought I was going to be a foregut surgeon, and I went to fellowship thinking I wanted to do foregut, and I'd never seen a retrorectus repair or a transversus abdominis release until I went to fellowship, believe it or not, and I really enjoyed it. And so kind of transitioned and went to every hernia case I would and avoided the foregut a little bit more. And I tell my residents the reason I love having a hernia practice is that all the hernias are a little bit different. There's a lot of creativity to, okay, it's a third redo, and what was done before, what can I do this time? So there's a lot of variability in the cases, and I sleep well at night. I tell them that I'm not worried about anastomotic breakdowns and, big bleeds. And of course there are complications, but overall quality of life I find is very good. And that patients are really thankful for getting hernias repaired. So that's why I love it. And I love teaching and the technology advancements. I mean, we're doing things that we simply weren't doing 5 or 10 years ago, and that probably 5 and 10 years we're going to be doing even new procedures that we're not doing now. And I really find that fascinating and fun to be in this field currently.
Well, I'll jump in. My background is completely different from the rest of the women on the panel, in that I didn't do a hernia fellowship or an ab wall fellowship or even an MIS fellowship. I was very interested in hernia and abdominal wall reconstruction during residency, and basically scrubbed as many cases as I could while I was a resident, but went on to do a trauma and surgical critical care fellowship. And when I came back after fellowship, I took on a lot of the complex ab wall cases and the hernia cases, but those were predominantly done open, at least by me. And most people, I think at that time, doing big posterior components were done open. But it was hernia that got me interested in learning robotics to be able to expand my MIS skill set, going to all of these meetings, such as like AHS and the other hernia meetings, doing a ton of courses, cadaver courses and what have you, to be able to gain the skill set in an MIS way and learn more about even open hernia repair. So I just loved hernia repair from a trainee and took a completely different route to get here. But I mean, that's my whole practice now. I don't even do trauma anymore. I just do emergency general surgery, critical care, and ab wall basically. So, and like Sabrina said, I mean, absolutely love to teach it to anybody that wants to do it, but, and continue to learn from everybody, you know, including everybody on this panel, because it is always changing. So.
Nice. So we have.
Oh, sorry.
I'm so sorry. No, you can go ahead. I just want to say that Conrad is in our meeting. So we are going, we have a lot of stars here. Go ahead, Dr. Archana.
Well, I was just going to say, I think you have an example here of how everybody's path was like very different. I mean, I don't think I went into fellowship planning to do this either. In residency, the same way Anna has seen like really like very few robotic cases, I had seen one laparoscopic inguinal hernia repair, which was the most disastrous operation I'd ever seen. Patient was fine. It took 4 hours, and I thought, oh my God, why would anybody ever want to do something like this? And then I had a mentor who said, you know, you're good at this laparoscopy stuff. You should do this. And I was like, oh, okay, well, that sounds like a good idea. And I just went off to a fellowship to see what this was about, and was just very lucky to have a kind of a very broad-based fellowship with bariatrics, foregut, and ab wall as well, with some great mentors. And that's where I kind of developed my love for all of these.
Yeah, you know, Dr. Archana, that my first laparoscopic inguinal hernia was like that, like yours. It's like total disaster. But my father is a general surgeon too, so he helped me. But I'm stubborn, and oh my God, it's not a disaster because the patient was he did well. But you know, after that, okay, I'm going to learn about hernias. Hernia is not just a hernia, and that's why we are here, and that's why I think that the societies are so important to the development of the surgeons, and to this. It's not about complex surgery. It's about inguinal hernias. This is so common, and if a surgeon knows how to do that well, we have a great outcomes, and I think that this is that. So, Conrad, are you here? I know that I can see your name here. Can you talk to us? Paulo, did you just
It's
allow?
possible to
Yeah.
yes.
Yeah, Conrad is here, but he
Don't
is
worry.
not going to talk. Okay. So we have like 10 minutes left to our talk. And we have here a medical student that he was like shadowing us in the OR, and we sent a paper to the AHS Congress, and he was selected to oral presentation. Sorry, for how can I say that? Poster presentation, and
or awards.
Yeah, and he was selected to the. He can like be in the best poster award. So where is he?
Rafael.
Yeah, Rafael.
I'm here.
Are you here? Oh, Rafael.
Thank you.
Hi. So
How are you?
I'm fine. What are you expecting about your first international
AHS
hernia meeting? And so he is going to the AHS meeting. So we are bringing a medical student there. What are you expecting about the AHS meeting?
So, hi everyone. Thank you for having me. I'm a fourth year medical student back here in Brazil. And like Dr. Natalia said, I'm going to present a poster that in the AHS meeting in the American Hernia Society. And it's a really good thing for me because I'm only a fourth year medical student, and back in March I was having an internship with Dr. Natalia and Dr. Paulo, and I learned so much from them. They are so good doctors, and they gave me this opportunity to present this e-poster. And the case is about a 34-year-old male with several hernia backgrounds. And these hernias surgeries that he had went bad and lead him to disability. And in the e-poster, we're going to try to explain to everybody how to avoid the patient having disabilities and how to improve surgery techniques. And I'm hoping that I can do well in that. Thank you.
All
Congratulations.
right. Congrats.
Thank
yeah.
you.
So Anna, it's another. She is a doctor already, but can you tell us about the research group that you have? Because I think this is really great that they just like do with us. So Anna, can you talk a little bit more about your research group?
Yeah, we have a research group that basically performs research on general surgery, but especially hernia surgery, abdominal reconstruction. And we were able to send 14 abstracts to the AHS, and I'm going to present 3 of them as an oral presentation. I'm really happy. And I think it's really great for me. I graduated recently, but I feel like as a student, and this is very important for me, this kind of exposure for me to grow with this, and it really develops us as students. I'm very happy and excited.
Yeah, that is awesome. So guys, this is what I think about hernia. You know, when you talk about the hernia friends, we have great mentors when you go to the AHS and the Brazilian Hernia Society Congress. We have like when you are in trouble in surgery, you can go with the best hernia surgeons and you can ask about that, and we can do that by phone or by the Facebook group that we have, the International Hernia Collaboration. And I think this is what the society means. It's a work hard, it's collaboration, it's having great people with great hearts and reaching like great outcomes to our patients. So we're like just in the end of our meeting. And I really want to thank, on behalf of the American Hernia Society name, really thank you for your time here. It was a great meeting, and I wish we can see each other on the Chicago Congress. And I'm inviting all the Latin Americans and the Brazilians to go to the AHS Congress. It's a very, very cool Congress to go. So that is it. Thank you so much for your presence. Right?
Thank you. Thank you so much.
Thank you so much for having us.
Thank
you.
you,
Excited to
guys.
see you all there.
See you. Bye-bye.
Bye-bye.
Bye.